Now, thank you very much for giving me the opportunity to present about sex and gender sensitive medicine in the context of this meeting. I'm very happy to share with you a bit about what it is that we're doing and what the basic concepts are in sex and gender sensitive medicine, and also some of the things we should keep in mind, especially as we move into a more digitalized healthcare. Now, we'll share my screen with you. And with that, give you a bit of an overview of what it is that we do. Well, most of you know that in the past in medicine, we have always considered and analyzed the human body, but the human body most of the time looked like this. Now, a few years ago, I would say a few decades ago, maybe, we started realizing in modern medicine that there was not just one body, but that there were at least two, and that they don't always behave clinically in the same way that we thought. So that was, of course, scary in a way. And while before we were mostly focusing on this body, we had to come up with a solution. And the solution we came up with was this. So what happened was that everything that was covered under this bikini was treated differently because it was obviously very visibly different. And everything that was not covered by the bikini and all the internal organs were treated as if they were exactly the same, regardless of the person. Now, as I will tell you in the next 15 to 20 minutes, this was not exactly a brilliant idea because it led to a lot of misconceptions in medicine, and it also led to a number of not so advantageous consequences, especially for every patient that was not a young and healthy male. Now, what is our perception of disease? All the diseases that we learn about in medical school, that we discuss with our doctors, are associated with certain images. So when I went to med school, and when any doctor goes to medical school to study medicine, we have to learn about the typical presentation of diseases, because when patients come to us, we need to be able to judge what kind of condition they could be having, and we need to start a diagnostic process. So what you're seeing here is a typical image of the heart attack that we learned for decades until we realized that not everybody necessarily has the same symptoms. So what you're seeing here is a typical presentation, and I still learned this when I was in medical school, which is not that long ago. This is the typical presentation of a male patient, which has had an abundant meal, is walking out in the cold, is probably a smoker, might have had a bit too much to drink, is not exactly physically active, and what he's feeling right now is this. He's feeling pain in this region of the chest, which is irradiating to the left arm. And this was the typical presentation of the heart attack that we learned about. Now, fast forward a number of decades, and we learned that not everybody has these symptoms, and that these symptoms can actually be quite different, especially if you are a woman, especially if you're a young woman. That doesn't mean that young women cannot have heart attacks with this kind of presentation, but the likelihood, especially of young patients, to not have these symptoms, but rather have other symptoms like dizziness or feeling out of breath or nausea or back pain is much higher than in the typical elderly male. If, however, you Google heart attack, what you get is this. And 3 years ago, when I first did this for my presentations, if you looked at the first 100 Google images about a heart attack, exactly 4 of them were women, and 1 of the women appeared twice. So let's say 3 women and a half. Now, things got a little bit better, because now if you Google the first 100 images of a heart attack, which I did in preparing this presentation a few days ago, 12 are women, which is already an advantage. And in 5 cases, there's a representation of both women and men, and potentially slightly different symptomatologies. So we're definitely going somewhere here, and we're also getting more attention to the topic. So we're moving forward, but this is just a heart attack, which is, if you want, one of the most famous conditions, unfortunately, where we know that there might be differences in presentation between women and men. Now, of course, this doesn't just go for heart attacks. because otherwise we would only work in the field of cardiology. It goes for a lot of other diseases as well. So for example, if you think about asthma, what comes to mind first is the typical wheezing sound that you have associated with an asthmatic attack, which is very common in boys, but not as common in girls, which a lot of times might have only dry cough at night and be diagnosed later because they don't present with a typical wheezing. When you think about Alzheimer's disease and the typical presentations that patients might display, women might have more emotional and behavioral problems, while men might have more physical impairment or apathy, which might lead to different diagnostic processes until we realize that our patient indeed has Alzheimer's. When it comes to autoimmune diseases, these are much more common in women than in men, although there are a few exceptions, but in general, they're more common in women. One of the typical autoimmune diseases that are much more common in women is lupus erythematosus, which presents with a number of symptoms that most of the time you can see in your female patient, because typical signs and symptoms are a malar rash, which is a reddening of the cheeks, and the nose phenomenon, which is change of color in the tips of your fingers, for example, when you move in from cold outside to the warm inside, and then, for example, change in the blood that you cannot see. However, these visible signs and symptoms, which can help the diagnosis, the malar rash and the Raynaud's phenomenon, do usually not appear in male patients. So a lot of times when male patients are diagnosed, it is later in the course of disease because, first of all, they don't have these visible signs. And when they are diagnosed, a lot of times they already have an affection of the internal organs, which also associates with a worse prognosis, with a worse course of disease. It's not just about the symptoms. Of course, this affects also diagnosis and management. And there are all kinds of differences that have been described in the literature. So for example, the diagnosis of women with bladder cancer has been described, and this is improving now because there's more awareness, but in the past, a lot of times women with bladder cancer have experienced delays in diagnosis because one assumed that they had in fact a urinary tract infection. When they went to the doctor saying, I see blood in my urine, the first thing that comes to mind is a urinary tract infection, which makes sense because it is the most likely thing to happen. However, if after multiple courses of antibiosis, so if you take antibiotics, nothing happens and the blood is still there, one should switch and start thinking about other possible diagnoses. When it comes to depression, what we typically associate with depression are feelings of sadness, of tiredness, of lack of energy. And these are more common in female patients. They're much less common in male patients, which, as I said before, doesn't mean that male patients cannot have these symptoms. However, they might also present with different symptomatologies, being more aggressive, being more risk-taking, having more behavior of abuse, for example, drinking too much, taking drugs, and so forth. So, for example, when it comes to depression, in the past, if you only used the criteria of sadness, tiredness, or lack of energy, you might actually miss a lot of diagnoses in your male patients. When it comes to osteoporosis, which we typically associate with postmenopausal women, it's a disease that is typically seen in our societies as affecting postmenopausal women because this is the group that is most affected. However, when you actually look at the population distribution of osteoporosis, you will realize that above the age of 70, 30 to 40% of men also have osteoporosis. Yet we don't systematically screen them, so a lot of times we only find out if they actually break a bone. This gets even more complicated when diseases are difficult to diagnose. So for example, multiple sclerosis, which is also an autoimmune disease and also difficult to diagnose. A lot of times patients with multiple sclerosis have a very long patient journey, a very long history before they actually obtain a diagnosis. Because a lot of times they have symptoms and then maybe for a long time they don't have symptoms until they have these symptoms again, which makes diagnosis more difficult. And if you ask these patients which kind of specialists they have seen before they actually obtained a diagnosis, men are much more likely to tell you that at a certain point they saw an orthopedic surgeon, while women will tell you that they're more likely to have seen a psychiatrist, where usually male patients with MS are never sent to. So we still have a long way to go, although things are progressing, as I showed you with a heart attack. Now let's try to bring that a bit in the context and content of digitalization of health and of the future of health. Where are we going? Which kind of questions do we actually take with us? So one of the first questions to think about is, when we acquire data, what are we actually measuring? It's not that easy, because if we talk about sex and gender sensitive medicine, we talk about different layers. So when we talk about sex-specific medicine, it is about the biology, about hormones, about genes, about anatomy, and how all these things can differ and potentially affect the course of disease, as I just explained. However, when we look at gender and gender-sensitive healthcare, we're thinking about other dimensions that also affect us as patients and physicians and human beings, and that can affect our interaction with the healthcare system. And this goes from identity, which means who am I? Am I a woman? Am I a man? Am I a non-binary person? To the roles that are attributed to us in society. So what does femininity and masculinity mean in the year 2023 in a city in Italy right now? So what does that mean? What kind of assumptions are being made? What happens if you don't comply with these assumptions? And how does it affect your healthcare? Number 3 are gender relations. So when you, with your identity, are confronted with the roles of society, how does that affect the interaction with other people, for example, in the healthcare context? So if you go to your doctor, which kind of assumptions does your doctor have? Which kind of identity has the doctor? Which one do you have? And how far does it affect if you're being taken seriously? Which kind of diagnostics are being suggested? Which kind of therapies are being proposed? And then there's another layer, which is institutional gender, which goes a bit beyond that, which is basically to describe how all our systems, our organizations, the healthcare system in itself, our societies in themselves do have gendered aspects and have been built on certain assumptions about gender in the past. So when we want to collect data to help future research and improve our products, we need to think about what is it that we're actually asking about, and in how far is this relevant for the products that we design. The second point is, if you design a product, will that actually recognize your user? And what I'm referring to here is a very relevant experiment conducted by Joy Buolamwini at MIT, which has been also represented now in the Netflix documentary Coded Bias, where she actually showed that commercially available facial recognition softwares were indeed biased. And depending on whether you were a woman or a man, and depending on the color of your skin, the commercially available algorithm would recognize you more or less. Needless to say, if you are a white man, you're most likely to be recognized correctly. And you see that here, light complexion, men, and you see that the errors are the smallest. And then there are different types of biases. Some of these systems are very good in recognizing light colored skin people, so they do pretty well on females as well. And others are pretty good at recognizing men. So they don't do very poorly when the skin color changes, as long as you're a man. If you become a woman, it's an issue. So if you're a dark colored female, you're the most likely to not be recognized. Why does that matter? Well, of course, it brings in a number of biases. And of course, it shows us that depending on how you train your algorithms, these will affect the data. But it has an implication in healthcare, for example, because as we've learned, for example, when you want to measure oxygen in the blood through the saturimetric measurement, which we've all learned about during COVID-19, if you have darker skin, these systems have not designed to work as well for you. And the same goes, for example, for the recognition of melanoma on darker skin, because a lot of the algorithms don't really perform that well. So this is something that's also affecting the medical care we can provide. Then if you develop a product, the next question is, will your user be able to use your product? What you're seeing here now are relatively simple aspects that do affect the performance of healthcare. So what you're seeing here is a surgical instrument being held by one of my women surgeon colleagues at my former workplace in Berlin. And you see that holding this for a number of hours is quite uncomfortable if you have a hand that is smaller, because your entire body might be smaller. If it has been designed for a stereotypical male surgeon who is 180 and has a bigger hand, it might not work as well for you. If you think about all the apps and all the things that we're developing for cell phones, this is another issue. How well do these work in the hands of a user that might have a smaller hand? So does your product actually work for everybody, or has it been designed only for a small group of the population? once you start asking about gender, you're also facing other questions. Can you actually guarantee the safety of this data? This is something we should keep in mind, because especially when we start moving into asking not just about biological sex, but also about gender, because it affects our interaction with the healthcare system and it can lead to potential biases, we should also think about and be mindful of, is this data going to be stored safely? Just think about the fact that sexual orientation is still punishable by death in a number of countries. So if you collect this data because it is important to whatever product you're offering, make sure and be mindful of the fact that this can be a safety hazard for some of your users. And the last one, and this is one that comes very close to the medical field again, is the development of apps. We have more and more apps that help us in predicting how our health is going to be. So we can collect all kinds of data about what we eat, about our menstrual cycle, about how much we move, all kinds of preventative things. But there's also a number of apps that predict if you have a certain risk of having a certain disease. And so the way this works is you tell the app what kind of symptoms you have, and then the app spits out a number of diagnoses. And what you see here is an example of a chatbot. And you tell this chatbot that you're 56 years old, you smoke 10 cigarettes a day, you've had a painful left arm for the last hour, remember the first pictures I showed you, and now you feel sweaty and sick. So if you tell the chatbot that you're a man, what it will tell you is, well, you could have a pericarditis, which is an inflammation of the heart, and you should go to the ER. The second option, you could have unstable angina, which is also a heart issue. You should go to the ER. The third one is you could have a gastritis, which is an infection of the stomach. You can go to your GP tomorrow. Number 4 is you could have a panic attack, stay at home and breathe. And number 5, you could have a heart attack. This is also something you should go to the ER to. So I would assume that by now, if you're a man, you're on the way to the ER. If, however, you tell the chatbot you're a woman, the first assumption you will get is you might have a panic attack, stay at home and breathe. And number 2 is you might be depressed, which you will probably be if you find out that you actually had a heart attack. Now, the chatbot is not consciously trying to kill you, I would assume. There was for a while, I don't know if this still works on the new version of Twitter, but if you actually use the hashtag #deathbychatbot, you could find more examples of this specific product, which fortunately, and for obvious reasons, never saw the light of day and didn't get an approval, but it will show you these potential biases. Of course, what's happening here is that the chatbot has been trained on historical data. And being trained on historical data, it reproduces the biases that we've had in the past and that I described before. So it is basically impossible to have unbiased data. All our data is biased in one way or another, but it is important to be mindful of it and to correct for it in order to avoid reestablishing these kind of biases in the future. And with that, I have some aspects to consider before I finish, and I would like to leave with you. Well, first of all, look beyond the bikini. And what that means is really when we look at healthcare, we cannot stop at the obvious differences. We need to consider the fact that there might be differences in all organs of the body and that they might affect all kinds of healthcare interactions. You should consider sex and gender and diversity in your team, because research has shown that diverse teams take these aspects, sex and gender especially, more into consideration, and also a number of other aspects. So if you want to build a product and if you want to make healthcare more inclusive, you need more inclusive teams. You should consider sex and gender at every step of the process. You cannot develop a product and as an afterthought say, oh, wait a minute, we should have thought about this in the beginning, because you will not have the data to actually make sure that the product works. So it is something you need to consider from the beginning. You should talk to experts who know about these differences. It's not that easy. It is not rocket science, but it's also not something that is that easy to do. So get in touch with experts. There's a lot of people out there by now who have experience in this field and who can help you. It is important to look at the science that backs up your product. So if you develop a chatbot, for example, look at what we already have in the literature and take that into consideration when designing your product. You should also evaluate the market for your product from a sex and gender sensitive perspective. So who is going to use this? Who are the end users of your app, of your product, of your cell phone, of your mechanical tool that you're going to provide to the community? And of course, the last part is spread the word about this, because although it is becoming more well-known, it is still somewhat of a niche product. And with that, I thank you very much for your attention, and I wish you a very enlightening rest of the conferences. Thank you very much.